now we go on to CTO and complex coronary artery disease. We have a demonstration of CTO, SVG angioplasty, and we have been very interesting lectures coming up regarding left main as well as the embolic protection, and then PCA versus CABG stimulative talks.
So this is a 58-year-old guy who has diabetes for the last 10 years and is a hypertensive, and he is a smoker as well, family history of coronary artery disease in the father. Had chronic angina for the last 4 years and recent worsening for the last about 4 to 5 months. And he had a prolonged episode of rest angina 2 weeks prior to his admission in April 2001. And this time round the troponin was negative. And if you see the ECG, I'll just bring up the ECG in the screen. ECG showed a complete right bundle branch block pattern. No significant STT changes. So his recent episode was prolonged rest pain, complete right bundle branch block which has been there for a long time, and troponin was negative. His echo was more or less fine, no significant RWMA, ejection fraction was normal. So he had a basic diagnosis of chronic stable angina, diabetes, hypertension, and recent onset unstable angina with normal left ventricular function. And we'll just run the angiograms for you. So this is the left coronary injection done from the right radial route and shows a mid-segment LAD disease and some disease in the left circumflex, which will be subsequently clarified in the other views. The right coronary, if you see, it's filling retrogradely. And this is the RAO view of the same patient, the LAD disease, which is again not well profiled here, but the left circumflex disease is a long segment disease.
Make it faster.
Again, the RAO cranial view just giving you the same information. The LAD disease is better profiled, and the just show you the native right coronary injections as well. And this is the artery which Dr. Goyal is targeting today. It's a chronic CTO, and if you see this, and this is the RAO view of the same RCA. Bridging collaterals are there. Just like to take over Dr. Goyal from here.
You come in. Okay, so Dr. Sharat Chandra.
Angioplasty runs.
So this was the angiogram at that time when the patient had presented with some rest pains, as he said, and he has angina of long-standing duration. So seeing the angiogram, what we thought, if you have any opinions you can say, but we'll go to the present situation now. So considering the angiogram at that time, what we considered was that the LAD and the circumflex, especially that severe circumflex long segment disease, was probably the culprit for the rest symptoms which he was having. So we planned that we'll do the LAD and circumflex that stage to make him asymptomatic, and then do the RCA as a second stage procedure, which was CTO. So we did that, and now we can again show from the laptop. Can we show the, go ahead please, So that was the procedure being done in April, and the LAD, as you see, has mid-segment severe stenosis. And go ahead please. And so we did that, and we put I think this is a cipher 2.7523, and that was okay. And then we went on to the circumflex. Next please. So that was the long segment disease in circumflex, if you can see, which is, and there's a OM coming in between, which is open from its mouth. So we in fact did some balloon of the OM and stenting of the main circumflex. And if we can, that's the wire across, and if we can see the final result, so that is what it was in the, that's the AP caudal view, and we can see better in the LAO view. Can you show the LAO view, next one? Okay. So that is what it was, all right?
Yep, the results of both the vessels look very good.
So now what we have, so now can we go ahead further? Next. Okay, so now the current status is, like, for completeness of revascularization, well, I had thought that we will do the RC. As you see, it's a big artery, but angina is to a large extent relieved. So we did a MIBI perfusion scan to see whether what we are doing, is it really needed or not. You can have a discussion on that. And so the MIBI scan incidentally was positive for reversible ischemia. You have some pictures there. I don't know if you can, it's a little busy set of pictures there. I don't know how to show it to you. So there are, the top two are cut sections. Adit, if you can show the marker there.
Stress and the rest images, this is the long axis view. There is a defect in the inferior area which gets filled up on the rest images.
On the rest image.
So it's quite classical that the inferior area
There
is
is some
ischemic.
ischemia, although he is not having that much of angina, because the instability was probably being produced by the LAD and the circumflex lesions,
Yep.
which has been taken care of.
Yeah,
So with that in mind, so now we have the patient on the table. So can we see the current? No. The laptop is over. So that is the current this thing. Because we had done a radial procedure earlier, so I wanted to do it again radial, but incidentally the pulse was not good, because sometimes, you know, post radial procedures the pulse gets lost or gets diminished. So we had to do a femoral this time. So the LAD looks all right, and this is iliocranial view, and so does the circumflex. There seems to be some mild disease at the bifurcation point in the OM, but on a still frame we saw it doesn't look that much. So that's the circumflex result now. And that's a straight LAO view. Yeah, that shows it better. If you can see the OM origin there, I think it is looks reasonable to me now.
Okay.
And that's the right coronary. Okay? So, you have any thoughts? You want to suggest me something?
Yeah, it's the right kind of lesion for a guy like Goel.
So, this lesion incidentally has, there are some good parts in it. There's very heavy bridging collaterals.
Yep.
So, the bridging collaterals, it is giving me one thing it tells that it is really chronic. But the only good thing is I don't have to do a counter injection, because it is filling through the collaterals antegradally. So one puncture is doing my job. Otherwise, I would have had to do a opposite side puncture to look for the distal vessel, because that is what my landmark would be for crossing the lesion and putting the wire in. So that is it. So if you want any other suggestions, or I should go ahead with the case now?
Yeah, you can go ahead with the case.
So now you see what, are you with me?
Yeah, we are with you.
So what I would think, as I told you that, okay, so now there's heavy bridging collaterals, so that says that probably there is a chronicity there, true. But one good thing which I can see in this patient, I think angiogram has to be very well assessed for CTOs. The point where the lesion starts, I feel there is a small nipple there.
Yep, correct.
So maybe a wire will go into that. And what I usually do is first I try with a regular type of wire and explore the lesion as to how chronic it is. Can I see a whisper wire, please?
But you know,
I will.
Dr.
I will
Goel,
now. I'm just taking a whisper wire.
No, Dr. Goel, it really doesn't look like there is any antegrade flow in that. It's not one of those cases where you have some very fine track and you can try.
Yeah, there is no antegrade flow.
Yeah, I really wonder whether at any point is there in trying with the whisper.
My only.
Are there any comments from the house about this case, the choice of wire?
You need a tough wire. I know
first
that.
guiding catheter is important.
Who's speaking? Any comments from the floor?
Sarath, I might...
Angio, show the whisper ka angio. Haan, chalao.
Now, Dr. Bansal, now it is too late. It's too late. He has already stented twice, and you know, Dr. Goel is in a mood to go ahead. So, yeah, you have something to say.
Yeah, there is a small nipple at the side of the lesion, but
So this is
it's
only
going to
to
be a
explore the
challenging case
lesion.
because the big collateral is very, very
Can I,
close.
have
So
a
sometimes the wire keeps on going there.
What wire is this finally? Is a whisper wire?
Haan. Nahin. Oh, well, this is just a whisper. Okay, so there it is. But I just want to see how much backup will be there, because
No, guiding catheter amplage is
prefer using
better.
a stiffer wire, because whisper is a hydrophilic wire. Sometimes it goes the wrong way. Well, it is showing some, but I don't think that's. You see, my guiding catheter is coming back, so that means there is some resistance there. I will not proceed with this. I will not proceed with this. Let me let me have a micro catheter and a fielder FC.
Dr. Goel, you have got a good
what I have
progression.
taken is a micro catheter now.
Go ahead.
He's got a good progression with Whisper.
But there was it was coming back. I don't want to explore.
He will get the support with a long sheath. If he takes a long sheath, then he might get a support. And
What I
Sheath, actually.
Okay.
120 centimeter sheath will give a good
well
support.
for support I am taking a micro catheter this time.
No, first guiding catheter, amplage one is a better one here rather than
taking a
Jutkin,
micro catheter. Can
because
you put
this won't give a proper support actually, because a true old CTO.
The support is not good. I agree on that.
Of course, you can take extra support by taking a micro catheter, and you can probe with a hydrophilic filter XT whether micro channels present or not.
Yeah, Dr. Bansal, sorry, Dr. Goel, would you give a test shot now and see what is the effect of the earlier wire passing?
Yeah. Inject. Come on. No, there's no channel that I see. Anyhow, I am trying a fielder XT, and if this, and I will not be too persuasive on that, and soon I will change to a conquest if this doesn't go. Okay. किसकी? हाँ, you can show the fielder XT.
More support. Jutkin, true CTO, it will come out entire count.
So that's the fielder XT. Actually, the guiding catheter is backing up. I think it needs the amplards. I think.
Amplage, exactly. You are
Amplage
correct,
would
Dr.
be
Goel.
I think you need a better support.
Clearly better choice.
So
Amplard
you can
will
have
sit
some
there.
discussion. I think I'll change it to amplards. Okay?
Dr.
I'll change it to
Sarachan.
amplards. This
Dr.
is not
Sarachan.
giving the support.
Dr. Surya Prakash here.
Can I have the amplards, please?
Actually, this should have a amplage catheter with side holes.
Side hole, eh?
Very important side holes. There is side holes definitely will, that damping thing will take away from your procedure in this type of cases.
Dr. Goel, do you have side holes on your amplage catheter, or this is without side holes?
Yeah.
Are there side holes on the guiding catheter you have chosen?
Well, this one doesn't
The
have
second
side
thing
holes, but I'll
very
see.
important is whenever you should have a
Well, the
micro
earlier one
catheter
had
support.
side holes. Earlier one had side holes.
To negotiate the micro catheter, first software you should try until you cross the bend, cross with a software. Because if you put directly a stiff wire, any stiff wire with micro catheter, the procedure ends there with a dissection at the proximal end. You cannot proceed further. It's a very important point in CTOs of the RCA.
Pressure. Test.
You're pretty deep-throated.
Yeah,
need
this
a side hole,
catheter
there's a
by
side hole,
definition will always land
Allow.
like this. It's difficult to place it
Get a
anything
6
less
inch
than
side
this. See, if you pull it, it cannot be adjusted. So that's why the suggestion that there should be side holes is
Side
quite
holes,
a reasonable thing. We will go deep into that. Most of the dissections which occur in the
Yeah.
are
Because
with the amplage catheter.
We are taking. Like. Side one? Wire in. Fix. Out. Flush. Pressure.
Yeah, this is good.
Okay. Can I see that? Can I see an angiogram, please? Okay. Inject.
This seems
All
good.
right. So
Reasonably
that's the amplage with a side hole there. Live. Hi. Fielder XT. Fielder XT डाल दो. So that's a micro catheter which is fine cross. Can you show the fine cross micro catheter? Back.
इधर फोकस कर दीजिए यार इधर
ठीक है ना वायर ऑन.
अच्छा उसके वो लगा हुआ
Okay. Hold on. Wire introducer. Oh, sorry, doctor. Yes, please. Just hold on.
Are they getting? ये मिल रहा है ना? Image.
What wire is this?
Okay.
Fielder XT with micro catheter support.
This is a Fielder XT.
Okay.
Yes, please. If you can show my, is it backing up? Test please.
हाँ आगे गई ब्रेंड को क्रॉस तो करी
So now what I am doing is just rotation and let the wire go. Just rotation, no pushing. If you can show my hand.
It's traveled a great lot already.
Test please. Yeah.
Almost through micro channel. It is
You see, the trick here is you should not be pushing it. That's the most important thing.
Rotatory movement.
Let it find its way. Because actually XT I found is very good, especially if they are micro channels. This did not show micro channels, but seems to be. So you should always try once with that. Test please. But no, but we have to see it in other view also. Sometimes you get fooled, you feel that you're proceeding in the right direction. Can I see in RAO now? Because it should be heading in the same direction in both the views, otherwise you will be fooled. Inject please.
Yeah, it looks
can you stop it? Freeze. Well, looks okay. It's heading in both the directions there.
सर पूछ लीजिए पैनलिस्ट का क्या लगता है?
So you feel it is going in the right direction?
It seems the resistance at the distal cap.
Because you see the distal fibrous cap is another part which is difficult to. Yes. So I think it is.
You have to exchange with a harder wire
Penetrating the distal
because
cap.
it was stuck there in the heart tissue.
That's what I feel. I'll try to get the micro catheter forwards if it is possible. It is not moving much forward.
Dr. Goyal, you want
Now,
to take directly Conquest Pro or you can
Conquest
try
Pro,
Miracle?
I'll show you one. Yeah. No, I will go straight to Conquest Pro now. I usually, I use a Whisper oblique Fielder XT oblique CrossFit 100 for trying to explore the lesion, and Fielder XT is best if there's a micro channel it will go through. And Whisper I know is not aimed to be going through. What is the best? The wire which is aimed to go through is Fielder XT. And after that, once I feel that this is not going, then I'll change straight to a Conquest Pro.
Actually,
Because it is better to have a stiffer wire and head it in the right direction rather than a softer wire which will slip across a tough obstruction and go subintimal.
Yeah.
I hope you get what I'm saying.
This is the routine
Now this
strategy.
usually I make two bends. If you want, can you show this bend?
No, this is the routine
The first bend
CTO
is very
strategy,
small
anti-grade, where single wire
I
technique.
don't
First you
want to
probe with a hydrophilic Fielder XT. Then if any resistance is there in the heart tissue, you exchange with a harder wire like Miracle or Conquest Pro.
So we make two bends. The first bend is about 45 degrees to 60 degrees and second bend is about 15 degrees. I don't know whether you can see it.
No,
okay,
it's,
in the wire.
Can you zoom it and show?
दिखाओ ये दिख रहा है?
Yeah.
Can you show this please?
Okay,
so
that's better.
कहाँ रखो? ये So there is a 15-degree bend proximally, and there is about 45-degree bend distally only in 2 millimeters. Because now the proximal bend will help me redirect the wire by how much it is outside the guiding and how much it is outside the microcatheter and how much inside, by changing that. Okay. So now this is a very stiff wire, so one needs to be very careful and just make sure that you're heading in the right direction. That's it. Come on, Anjo, please. So now you see it is heading in the right direction. And only rotation, if you can show my hands please where I'm rotating the wire. So I'm inside here, but let me see in RO.
Yeah.
Because you need to see in both the views. Anjo, please. Yeah, both are probably inside. I don't know, what do you feel?
It could still be
What does the house feel? Am I inside or am I not? Probably subintimal. LAO, please.
Dr. Goel, another view is a left lateral view for this.
Just see how it is. No, as long as you see in two orthogonal views, it is okay, Dr. Sharachanda.
How is the wire movement? Is it free or?
No, the movement of the wire is not really free. I mean, if it has entered the true lumen, by now it should be moving better.
No, it is.
Can you see that our second view again, the RAO, there it appears slightly eccentric.
Yeah, that's right.
Test karo. Can we have a test, please?
The flow has reduced.
Test, please.
Whenever you have a wire and everything there, signals are blocked.
Test, please.
No.
Yeah, now it might have entered the true lumen
Please.
again.
I think it is in the
Lateral view may be better.
You see now that it's because I am still proceeding very carefully. You see, I am still proceeding. एक second. Because the other thing is, if it were in the false lumen, it would have given me resistance. It is not giving me resistance, and I am proceeding in the curve of the artery. So I think probably it is inside. We'll confirm it now. Angio. Okay, so that's the LAO, and now let's see the RAO. Come on.
Your tactile feeling as if moving in the free movement or any tactile
Yeah, I
feedback
think
you
it is
get?
inside. Yeah, you see, I think what I am trying to tell, this point is very important. When you are seeing it in both the views, and both the views, the wire is falling in the silhouette of the distal vessel, it is inside. So I am quite sure it is inside. Can I go back to LAO now? Now these steps also have to be very careful, because there are instances where you might cross it all right and then get extra subintimal. So you have to really proceed very slowly, and I am just rotating still and I am not pushing it much. Test, please. I think that's fine.
That's good.
So now it's okay. I think it's okay.
Yeah,
All
maybe
right.
you can try your micro.
So now I need an extension. I need an extension, please.
Low profile balloon.
Well, I'll try a balloon straight because there's no point just putting the microcatheter. Come on, extension of the Asahi. I usually change it with an extension. I know there are some experts who want to do it by trapping the wire and all. You can do that, but I feel more comfortable with an extension. It takes a little while, but I think you are more sure that you will not lose this access now. Okay?
Balloon trapping method.
Yeah, please open it.
Their mother
Now, अब इस वायर का कोई गड़बड़ नहीं करना. So the micro is coming back. Just close it when it comes. Close, close. Okay. Just hold on. All right. So now this extension goes out. Now I need a good balloon. Now let us try a mini trek. A mini trek 1.212. So this is a mini trek. This I find is a good balloon to cross. If it doesn't cross, then we have a still better one, and that is acrostat. So let us see. I'll try both of them. So 1.212 mini trek. This is from Abbott, I think.
Dr. Goel, a couple of points.
Come on.
You having opened a microcatheter, you know, many people, many of us would have, if you had not used a micro, in fact, we don't use microcatheter at all. But if you use it, you could have just passed it a little more forwards and given an injection through that.
Well, I also don't use.
That would give you a very good opacification of distal vessel, and
Dr.
it will
Sharat.
confirm to you. No, I'm just saying, because this is a teaching exercise here. You know, I thought you are going to demonstrate that you are in the distal lumen. Anyway.
Sharat, I'll tell you one thing. To check whether it is in the correct lumen, I believe on the angiogram and my orthogonal viewing, and that is what I was trying to show you. I somehow am reluctant to do an injection in the distal artery, because if it is not in the true lumen, then you had your day. Then you will not be able to do anything. You get my point?
Not necessarily.
So
you know,
that is the thing. So I don't do that. I know some people. Where is the balloon? Has it crossed, or where is it? Not yet.
Already it crossed and went
distally. That's the balloon coming up, and there it goes. Okay. No, it didn't go distally. So that's a 1.2 balloon. Shit, I should have gone distal.
Actually, for audience sake, there are three types of low profile hydrophilic balloons. One is acrostat 1.1, and second one is thermo, this is 1.25, and this is the newer one, Abbott vascular mini trek 1.2. So these are the one after removal of the microcatheter to go into the total occlusion. This balloon will be advanced.
See, the microcatheter has a profile which is higher than a balloon.
But difficult to pass because non-hydrophilic nature.
That's what I'm saying. Acrostat has the lowest profile.
Yeah, that's what I'm saying. If microcatheter has gone, a routine balloon would anyway go.
Acrostat.
You don't need an acrostat-like balloon. The microcatheter has a significantly higher profile than a...
That is why I have not used acrostat.
So, even this is a very low profile balloon. What company is this?
Abbott vascular.
Abbott.
Abbott vascular, mini trek.
What company is this? Which? Acrostat actually is 0.15-inch crossing profile. Give me a 2.0 balloon.
This is another balloon.
That is the lowest profile, 2.0. Any balloon.
Another balloon, Falcon balloon, 1 millimeter. That is one lowest profile is Falcon. Balloon 1 millimeter.
Yes. I think 0.15 is the lowest profile, if I am correct. I don't know.
Contrast was too
0.15 is the lowest profile. Can I use a 2.0 balloon? 0.15 crossing profile. Come on. So I'm just using a routine balloon now. This is a Sprinter 2.0, I think. I hope that will now cross 210. Come on. Open it first. You see, because we're doing live, so I'm using all new balloons. In my regular practice, I might not have done that. So you have to, otherwise I would have maybe used Oxford balloon or things like that.
No, we thought yours is a rich hospital.
once you have crossed it with the first crossing is difficult. Ah, well, yeah, we can afford this thing. Let it go.
Sorry?
Just let it go distal most.
Yeah.
Okay. All right, just hold on.
I would have actually exchanged it long time back with a softer wire.
Even with the microcatheter in can exchange. Even now.
No, I will do it now because there has to be some good lumen there. Otherwise, sometimes.
Shashikant, what are you saying?
Yeah, the distal position of this Conquest Pro wire.
Yeah, Dr. Shashikant wants to know what is the tip of the wire, where is the tip of the wire?
The tip of the wire is not on the field, it may be moving.
Yeah, it is in the PLV. Yeah, no, but I am controlling it. You see, I know what you're saying, but I am keeping a very strong control on it and not letting it go beyond. So, inject please. Okay, so we have made a channel, so I think that's a good thing. Now we can, give me a whisper wire.
Pass.
Give me a whisper wire, please.
Now software you can pass and remove this wire.
Dr. Goel, what is the final diameter of the balloon you achieved?
Now, well, there are two ways to do that. Well, this is 2. So 2 is enough for me to cross the wire because with Conquest Pro inside, my visualization is not good.
Yep.
So I will do the further balloon after having changed the wire. You get it? So I want to now cross it with a whisper routine wire. My workhorse wire is usually whisper. Oops. Torquer, please. No, this is going the wrong way.
There is some disease proximally also.
Yeah, you need a long stem.
I can use a microcatheter, I know. Yeah, allow microcatheter though. Give me a microcatheter, please.
Let the microcatheter in exchange.
I think I'll use a micro. Give me a microcatheter, please. Extension though. Extension though. I think I'll use a microcatheter.
People routinely do.
See? That is a safer. Okay. Yeah, all right. Please thread. Adit karo. Don't dent it. Pani dala? Okay. Has it come out? Thread it in. Thread it in. Hold it. Hold it. Okay.
Somebody wants a mic there. Fixed? Can you give a mic there?
Okay.
You can come forwards and talk.
Fix the wire, please.
Fix.
Okay. All right. That's fine. Okay. All right. You see here, it was probably better to use a microcatheter because there is some proximal disease, and the guiding is not that coaxial, so you endanger dissection proximally.
I just wanted to ask one question.
Louder.
Now, when you're dealing with a CTO and you already use a link wire.
No, doctor, you're not audible. Just speak a little louder.
I was just wondering that when you're dealing with a CTO and you're using a link wire, why not use a OTW balloon, and after you have crossed and dilated, or as you've gone, then exchange the wire through the same balloon, rather than going through a microcatheter and or trying to pass another wire from the side.
Yes, doc.
That's what we said.
You see, you can use over the wire balloon. The only thing is, well, what you are more comfortable with. That's perfectly fine. You can use over the wire balloon. Then it will do both the jobs of dilating the lesion and exchanging your wire.
Yeah.
It will do both the jobs.
Sometimes over the wire balloon hinders the torqueability of the hardware compared to the microcatheter. Yes, we have seen so many times.
But in a CTO, over the wire balloon would always have a better pushability rather than rapid exchange.
Fix
Micro catheter exchange. They are removing the micro catheter.
Flush.
ठीक है?
हाँ मैंने.
No, they exchange with the whisper wire.
And we have a check angio here.
वायर को थोड़ा सा पुश रखो, वायर को थोड़ा सा वायर को पुश रखो.
पुश रखा है सर.
आ गई वायर बाहर?
नहीं अभी नहीं आई. अभी नहीं आया. फ्लोरो देखो.
Micro catheter.
नहीं आएगा तो मैं करता हूँ.
आ गया?
नहीं आने वाला है, बस करिए. नहीं अभी नहीं आया गया.
The whisper.
और कुछ ना करना.
कुछ नहीं कर रहा.
Okay. Leave it. Okay. Now get me a 2.5 regular यहाँ से. 2.5 balloon. Okay. Now we can see the angiogram.
वायर सब सही कर लिया. वायर सही.
ठीक है. That's okay. Come on. Let me see an angiogram. Inject, please. Okay.
Yeah, you made
so
the
I
channel.
think that is okay. So we need to do some more balloon work there. Come on. 2.5 balloon or
you have 20 minutes left.
Yeah.
You have 20 minutes left.
Yeah, so I think I have shown you the trick of CTO already.
Yep.
And now I'm just completing the job.
The most important stretch is over. That is passage of the wire.
If you have anything else, you can go ahead.
What size of stent you find?
Yeah, that is the main thing. And if you have difficulty in crossing with a balloon, then you might need sometimes you need something like a Torners or a Corsair to cross if the balloon is not crossing. Right.
But not needed in this case.
You see, can you show that from the laptop that slide, the slide of paradox? Can you show that?
There is a waist still in there.
Can you take a check and see whether the full length of the lesion is dilated?
Laptop दिखाओ उसको बोलो वहाँ से laptop दिखाए.
No, Dr. Goyal.
I'll just.
Let's see the result of this.
पीछे वाले. हाँ.
आगे.
हाँ.
balloon तो proximal नहीं किया.
You see, this is something which I wanted to show you. In fact, I several times don't use a support, but in this case I used it. And why? Because this is because of this proximal problem. You see, I'm dilating it there. There was proximal disease, and if there is proximal disease, so to traverse to reach the CTO, sometimes a stiff wire can damage the brachial prostimally. Otherwise, the feel that you get with a bare wire sometimes, especially with the stiffer bare wires like Conquest and all, is very good without the micro also. So I many times don't want to use a support, inject. But this case had its own special issues, so we had to use the micro. And I think the guiding has to...
Yeah, your point is well taken. To take the stiff wire to the point of maximum resistance, the other wire helps. It just takes it along by its side.
Yeah.
We should not use the stiff wire for crossing all those, avoiding all those branches and so on.
एक 30 का balloon दो. Yes. So you need it at that time, and then you need it sometimes when you have like you're doing a left coronary, and you have the angle of takeoff is different. So you need a different curve for the angle of takeoff and a different curve for entering the CTO truly. There again you need a microcatheter so that you can put that type of curve to the wire which will negotiate the lesion. Because otherwise if you have to give the curve which is needed for the for hooking that vessel, means for the angle of takeoff, that will not be optimal for exploring the CTO. I hope you get that.
Yeah, you are
so
right.
These are some areas where a microcatheter is very essential. Otherwise, 30 balloon please. 312. So actually I had just kept one case. I thought that it will take some more time for me to cross being a CTO, otherwise I would have kept two cases. Right.
But unpredictable CTOs. Some may cross easily, some may cross then you have to use a parallel technique.
Yeah, that is the reason.
Yeah.
You see, yeah, that's right.
No, just to provoke a discussion.
So here I think the only point in this CTO was that the distal fibrous cap was tough and the distal fibrous cap was the one which needed the conquest, truly speaking.
Yeah.
And your XT had crossed the major part of the lesion, but the distal fibrous cap truly was crossed by the conquest.
Yeah.
Test. Okay.
Which balloon is this? What size?
3 mm.
So we're just doing some graded balloons.
3 mm. See, just to provoke discussion, Dr. Kapardi, when will you use a microcatheter? When will you use a OTW balloon?
Usually it is operator dependent. Majority of the cases, microcatheter is useful because it won't affect the torqueability of this hardwire and tactile feedback we will get. Suppose if you take OTW, okay, it is easy, we can reduce one step. We can advance the balloon and dilate with the one and exchange with the software. But only the important difference is the torqueability of the wire will be affected. There is a balloon paradox, what we described.
You see, the tactile feedback that you get from the wire is very important.
Yeah.
And that is lost with the over the wire balloon. And the other thing is, you know, people feel that soft wire might be better, but soft wires sometimes produce more dissections than these stiff wires. Because soft wires, what we are using is the penetrating technology, penetrating technique.
Okay.
Soft wires will have resistance against the tough part of the lesion and will take the track of least resistance. Several of them are hydrophilic and they will immediately go subintimal. A tough wire, a stiffer wire like Conquest will head through the obstacles and go straight as long as you can direct it in the direction that you want it.
See, the point I was trying to say is,
okay, I think we'll just use
that's a good result. You can go ahead and stent it now. The point I was trying to say is, microcatheter, by its very virtue of having a higher profile, sometimes does not cross the entire lesion.
You are correct.
It may enter part of the lesion, but the real end it may not go.
Yeah.
So on the other hand, a OTW balloon with its much lower profile is more likely to go to the tip of the lesion. So in a relatively long lesion, a OTW balloon is a better choice than a microcatheter.
No, small suggestion.
If it is a short lesion, then microcatheter is a good idea.
No, small suggestion, Sir Chandra.
So I am using a 38 millimeter long.
Here,
What
is the diameter?
Length of stent do you expect in this, Dr. Sharath?
No, what is the diameter? I am more concerned.
Well, I am using a 3.5. Is that okay?
Yeah, that's right. 3.5. It will be something like
diameter 3.5.
30 plus stent is required.
And length?
Yeah, 30 plus. 30. You need to cover right up to the ostium.
30 plus stent is
right. Yeah. I mean, in fact, I would prefer if you take a couple of pictures and see. Yeah. What is it you see?
Actually, here the tactile feedback, why it is important? Because if it is stuck in the heart tissue, for a hardwire, it will penetrate and it may push out, perforate the vessel and push out the catheter also, guiding catheter. That's why always tactile feedback is necessary for whenever you are using hardwire. And whenever you have hydrophilic wires, you won't get tactile feedback. It easily it will go through into the false juvens. That's why microcatheter is preferred to OTW. Initially, OTWs are used, but nowadays everybody is preferring microcatheter only.
No, both have their own limitations. Both have their own limitations. Sometimes a microcatheter just wouldn't go forwards. At the same time, OTW balloon would cross. So both have their own limitations. I wouldn't say for every case you can use a microcatheter.
The OTW balloon has a lower profile.
That's what its profile being
so I would
less.
support on that point.
You can give a test shot in both of them. You can give a test shot to check whether you are in the right lumen or not. Yes, go ahead.
Microcatheter will have an advantage of injecting and
here in this situation, positioning of the guide cath is going to be very important.
Yeah.
You want to cover right up to the ostium.
Yes, doctor, go ahead.
Microcatheter will have an advantage of injecting and knowing the way. It's not.
Can you talk louder?
Microcatheter will have an advantage of injecting.
Yep. No, you can inject through an OTW balloon also.
But
it will not be, cannot inject.
It will not be as good as
in
micro.
There is a slight difference will be there, but you can inject. See here, he never actually checked whether he is in the right lumen or not, because he is very confident by its tactile feeling. But I would say for a relative beginner, a very good idea is to inject through it. Once you think you have crossed it, you inject. The contrast is going in along the vessel. Then that's it. You put another routine wire and remove it.
एक और लगा दूंगा, टेस्ट करो. इस एम्प्लार्ट्स की प्रॉब्लम यही होती है.
आएगा आएगा.
तुम इन्फ्लेट करो. Come on, पकड़ो, इन्फ्लेट करो. Go ahead. Come on, मैं गाइडिंग को बाहर करूँगा.
Yeah, when you go slightly higher on the pressure, you can pull it.
Right.
Yeah, now you pull the guide out.
Okay.
When you go slightly higher on the pressure, you can pull it. Yeah, now you pull the guide out.
Yeah, there was problem, you know.
No, that's fine now. Your stent is, it may be a little short, that I don't know, but
I think it's okay.
It's now properly implanted.
Yeah, because you know the problem with Amplart's guide is when you pull it, it goes in. When you push it, it comes out.
Yeah, not after the balloon is inflated.
So
Once you inflate the balloon to a small extent, then it stays there. The rest of the stent is already catching on that.
Yeah. Yes, and then yes, that's correct. So that's what I did.
It will suck. It will suck.
Deep throating all the time.
It will suck.
Yeah, that's part of the game.
Yeah.
You chose a catheter that is meant for deep throating.
The question is whether he has really covered the ostium. Let's see.
Yeah.
Looks like
Covered.
yes.
Covered.
Test, come on, inject. I think it's all
good.
That's a great job done.
Good.
Great
So
job.
are you okay with the result?
Dr. Goyal, all appreciation for you.
Test, come on, inject. Thank you. So I think we've done it just in time.
You finished
Maybe
earlier than that.
3 minutes.
Earlier, you finished earlier
So
than
is
your
that
schedule.
okay?
You have
Yeah,
one
but-
more case that you will finish in 8 minutes, you can do it.
But I think
You have one more case that you will
no.
finish in 8 minutes, you can do it.
Well, I had not planned it. I had thought this will take much longer. Yeah. I can show you one case which we did just day before. Show it.
Okay.
वो वाला दिखा दो. हाँ? अन्ना हजारे is there.
Oh, you did this case, did you?
The people are wondering you did Anna Hazare's angioplasty.
हाँ, नहीं, not Anna Hazare भैया. But Anna Hazare is in the air these days, you see, so everything is Anna Hazare. So, okay, so we'll get this out. So this was another patient that I just did, who was diabetic. Someone can tell. Can you just tell it fast? This patient actually, can you show the slide? This patient actually had long-standing angina. Laptop दिखाओ. नहीं वहाँ नहीं दिखेगा ना. He had long-standing angina and recent instability. Okay, and I'll show you the angiogram. Can you show the angiogram, please?
You know,
laptop se dikhega. Next, that's the ECG. So now there is no MI by ECG. There is no MI by ECG. So it is not an acute MI. Troponin is negative. He has a non-dominant right. Can you go ahead? Non-dominant right, and that's the left system. Okay. So that's the cranial view, and you can see he had a proximal circumflex very critical disease. LED is okay. He has a proximal circumflex very critical disease, and beyond that it is occluded, and it is a dominant circumflex.
Yeah, you have got
now with the recent instability, troponin positive. So I was thinking that, and the long-standing angina, one would think that maybe the circumflex occlusion is recent or not.
You want us to,
but what was there in my mind that probably the proximal circumflex is producing the recent problem, and the distal circumflex is a chronic occlusion. So anyhow, we took this patient up, and if you can see, can you go ahead? So the aim was we will certainly open the proximal circumflex because LED is okay, so he is not a case for surgery. I will open the proximal circumflex, and I thought that maybe if the distal circumflex is a CTO, I might leave it, or I will. So first I went into the OM, did the proximal one, and then The distal one did not cross with the regular wires, proving itself that it was a CTO. Next. Next. Go ahead please. Go ahead. And this is a dominant circumflex. So again a similar technique was used. Now you see this is a Fielder XT which has been put in to explore that lesion and see how much it goes. And this is, and then there is a parallel wire. The Fielder XT is bare, and the parallel wire which is coming through the microcatheter now is a Conquest Pro. Because the Fielder XT directed me into that lesion, and then the Conquest Pro crossed.